Okay, we're ready.
Okay, step two from Nanjing First Hospital transmission. And today we will give another case about complex bifurcation lesion, focus on the diagonal and LED. And I will introduce our colleagues to you. So previous is Dr. Yu, he's operator here, and Dr. Wu, his sister, and Dr. Gan, another sister. So please, would you please introduce the characteristics of the patient first? Dr. Yu or Dr. Wu, please.
Okay, thank you, Chief. Dr. Please introduce the patient's history.
Okay. Check the PPT for me. PPT. Good afternoon, Honorable Esper. It's my pleasure to show the patient's information. Next. Patient, 83 years old, May, post PCI for 1 year, recurrent chest pain for 1 month, risk factors hypertension, a little low EGFR, LVEF, normal, cardiac biomarker, T-wave inversion in the left 2, 3 AVF. We diagnose the patient as CAD, UAP, and OMI. Next. Last time, the patient got acute inferior myocardial infarction. CAG results show the middle segment of RCA's total occlusion. We use the 3 standards to solve this serious problem. After PCI, the patient had no oxygen and out of hospital. Next. This time, the patient had the pain, chest pain, again for 1 month. Spider and the liver position showed proximal LCX and the LED is borderline lesion. Next. RAO, LAO cranial showed the LED and the D1 is a fused bifurcation lesion. Next. According to Medina classification, it's a true bifurcation 1111. According to definition criteria created by Xiaoliang Chen, it's complex bifurcation lesion. Next. We also measure the QFR value. We see the low LAD and the D1 is proved coronary physical function. It's QFR value. Next. We also see the syntactic score to evaluate the risk stratification. Then we find the PCI is a good choice. And how we treat the LED and the D1 bifurcation lesion. 1 stand and 2 stands, and guidance what is treatment, IRIS and OCT. That's all. Thank you very much.
Okay, thank you, Doctor. You have given us a very brief and clear case history. So, Chief, can we show our strategy today? For that, I just want to show you today's angiography. Okay, you can see very clearly it's right dominant, and 1 year deployed the 2 stands cover the middle segment of IC, only minor lesion in the proximal IC. So IC is good. Next. Okay, it's the transfemoral approach is the 7 French EBU 3.75 guiding catheter. You can see the left corneal artery angiography. You can see only mild lesion in the proximal circ, and QFR is okay. But today our target lesion, just like Dr. have told us, is the LED and the first diagnosed true bifurcation lesion. Also is the definition to find the complex bifurcation lesions. And you can also see cranial view, please. Next view. Okay, cranial view very clearly. You can see proximal LED extended to the middle LED. You can see the diffuse lung lesion, and you can also see the severe calcified, and also muscle bridge in the distal segment of the LED. So this today's angiography. So according to the Professor Chen's definition serial data, we know that only the two-stent technique can benefit patients. So for these complex bifurcation lesions, our strategy just to perform the DK crush technique for this patient. Before that, ultimate serial trials have told us that the complex the lesion is, and the patients can benefit more from the intravascular imaging, especially IVUS. Just to concern, this patient is 83 years old with not good cardiac function and renal function. So IVUS is our preferable. Okay, so this is LAD IVUS and sequential the first diagnosed IVUS. Dr. Panto, would you show us the IVUS imaging?
Okay, let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. And here we can see the distal LAD vessel is normal. Then go on pull back, we can see muscle bridge. Then go pull back, near the muscle bridge, we can see eccentric plaque. So the distal landing zone is near the muscle bridge, and here the vessel diameter about 3.2 millimeter. Then go on pull back, we can see eccentric plaque. And here we can see calcified plaques. The calcification angle is not more than 180 degrees. So go and pull back here. This point is a minimum lumen area. The area is just 2.3 millimeter square, and the plaque burden is more than 75%. Then go and pull back here. This is a middle LAD, and here the vessel diameter about 3.5 millimeter. Then go and pull back here. We can see the guide wire. We are showing LAD, and here this is the LAD and the diagonal bifurcation. Near the bifurcation, over the bifurcation, we can see the calcified plaque. The calcification angle is more than 270 degrees. Then go and pull back. This is a proximal LAD. The proximal LAD vessel diameter about 4.0 millimeter. Then go and pull back here. We can see this is the LAD and the circumflex bifurcation. And here the area is about 4.5 millimeter square, and the plaque burden is about 70%. Then go and pull back. This is the POC, and this is the distal left main. The distal left main area is about 10 millimeter square. The plaque burden is just 55%. Then go and pull back. This is the body left main. The body left main vessel diameter about 5.0 millimeter. Then go and pull back. This is the proximal left main. Let me show from the distal landing route to ostium left main, the narrowness is about 48 millimeter. And from the distal landing route to LAD and the diagonal bifurcation, the narrowness is 29 millimeter. Okay, this is the LAD run. And the second run, we check IVUS from the distal diagonal to ostium diagonal. And here, the distal diagonal vessel is normal. The vessel diameter about 2.8 millimeter. Then go and pull back, we can see calcified plaque. But the calcified, then here, this point is a minimal lumen area, and the area is just 1.5 millimeter square, and the plaque burden is more than 71%. But here, the vessel diameter is just 2.5 millimeter. Then go and pull back. We can see calcified plaque. Then go and pull back. This here we can see is LAD guide wire. And here this point is the LAD and the diagonal bifurcation. And here this is the ostium diagonal. The area is just 2.4 millimeter square, and the plaque burden is more than 67%. Let me show the narrowness from the distal landing route to ostium diagonal is 29 millimeter. Okay, this is a baseline IVUS imaging. Thank you.
Okay, thank you, Dr. Pan, and give us a very clear IVUS image result. And just as you see that, we calculate this patient's IVUS calcium score is nearly 2. So the indication for the arthroectomy maybe is good. But here in China, we don't have the orbital arthroectomy. We just calculate the minimal diameter for the most severe stenosis is more than 2. So rotor arthroectomy is not good. And how about the reference diameter of the severe stenosis?
3.5.
3.53.
Yeah.
So here we have the Chinese domestic IVL device. We call it the T-Wave, just guided by our chief Professor Ye. So we just decided to perform the IVL to deal with the lesion of the middle segment of LAD. So we have ready. Here's the 3.0 T-Wave.
So we think this is a very interesting complex bifurcation lesion with a severe calcification lesion located at the proximal LAD. And from the IVUS, we can see the position upside the diagonal. There is a severe calcification lesion here. That's why we should use IVL to treat this lesion to prepare it better. Just because if we standing or predilate directly with NC balloon or conventional balloon or cutting balloon, we can see there is a severe plaque shift or a cranial shift to the ostial diagonal. That's why we should use IVL to treat this bifurcation lesion. Oh, this is a 3.0 IVL.
Yeah, 3.0 IVL.
We can see it predilate very well. We can see the balloon prepare and the full expansion with full atmosphere.
Okay, we finished the first round. 10 pulse. Okay. So Chief, how about? Okay.
Yes, it's enough, but we should prepare proximal.
Proximal. Okay.
Yes, proximal. Just at the side of the bifurcation.
Full atmosphere.
This is a T-wave domestic. Yes, here. So if we prepare the lesion proximal just at the side of the bifurcation, we can decrease the cranial shift or plaque shift during the Manvesa standing.
Good.
So this is a 3.0 T-wave full expansion.
Can we deliver to the distal segment?
Sure.
Okay.
Sure.
Okay, a little move forward. Okay, here, 4 inflate.
Just because based on the angel and IVUS finding, we defined this bifurcation lesion with a complex bifurcation lesion. According to the depletion trial, we will use a two-stand tactic.
6.
So today we will perform a DK crush to treat this lesion. But before standing, we should prepare the lesion well before standing. So one is LAD, so a little distally. Okay, just because middle part of the LAD reference diameter is 3.0. Japan, is that right?
Yeah.
Yes. So we use 3.0 1:1 T wave just as a shockwave balloon 1:1 size to prepare the lesion.
Equal to 6.
So after preparation, we should use IVUS to check again. If we find the calcification correction phenomena, we can standing.
Okay, Chief, we have finished the 4th round.
Yes.
Okay, last round. Yeah.
Yes, here is
go. 4.
Here is very important to prepare the bifurcation site. Sometimes we also use IVL to treat very severe calcification. Based on the IVUS, we will find the ring shape calcification and at least over 270 degrees, but we cannot see the thickness of the calcification. Okay, but Chief, we also can see, yes.
We have finished the 5th round. I think it's good. We can check
test. Okay. Test, Angel, please.
Test, please. Test.
We will see the
pressure is good. Okay, flow
is good. Okay.
Natural
so for back, we can, yes, we can check the Angel. We can check the IVUS to see that, yes, if the calcification was prepared well. So it's quite important to prepare the lesion well before standing, especially for the severe calcification. Just because minimal luminal diameter was over 2, in LAD. So rota is not suitable and not available, not suitable for this case. I think IVR is better than only rota. So after T wave, we check the IVUS. Yes. Nitro, please.
We have given nitro. Okay, here.
From here,
Go.
I will pull back. Is it distal LAD? It's a muscle bridge. It's a LAD vessel normal.
So it's very important to make sure the landing zoom distally. We don't want to touch the myocardial bridge.
Yeah.
Here's nearly normal.
Here maybe the proximal muscle bridge.
I
Here
think,
is normal.
yes, here the reference diameter was about 3.
3.
3.
How about
Okay.
here? Here.
Okay.
It's very difficult to make the distal landing zoom just beside the myocardial bridge.
Yeah. And here we find the medial dissection.
Yes, it's good for standing. Maybe it's not for.
Maybe here is a crack.
Yeah, we see the crack. Yeah, very clearly.
Here is a crack.
Yeah.
Sometimes it's another indication for standing, just for the T wave for expansion. Yeah.
Medial dissection.
No problem. I think the MRA was large enough.
Yeah.
Looks bigger.
Yes. Even though the eccentric.
Here we can see the bifurcation.
Yeah.
Side.
Yeah, the guide wire passing through the main vessel.
Okay.
The proximal LAD.
So from the IVUS, we also can see the middle LAD reference was 3, and diagonal was also 3 or 2.75.
2.75.
2.75.
Yeah.
So based on the Fend Muir HK format, so the proximal LAD reference about 4. But from IVUS, we can see the reference was 4. I don't know.
So Chief, seems like we prepare very good. So
yes, I think LAD preparation is enough.
okay.
So prepare the diagonal piece.
Diagonal, okay.
With a 2.
Give me 275.
275 NC balloon.
NC balloon.
NC balloon. From the IVUS, Pantal, could you tell me the plaque characteristics of the diagonal? 预角质的斑块性质是什么？
Calcified plaque.
A little calcified?
Yeah.
Fibrous. Yeah. This is fibrous. Approximately. Yes. Okay. 12 o'clock is LAD while.
Yeah.
Okay. Yes, based on the IVUS, we can use NC balloon. Yes.
Inflate. 6, 8, 10. Okay.
Sleep a little.
Down. Yeah.
Sleep a little distally. Make sure.
Yeah. Okay.
Yes. This
inflate,
is 275 NC balloon.
Yeah.
We can see a little sleep
10,
distally.
12.
If we find this phenomena cannot be avoided, we can use a cutting balloon or scoring balloon to prepare the lesion.
Inflate. 12.
So
okay. Good. Expand good.
Pull the diagonal wire a little back.
Okay.
To distal. A little back. Wire back. Yes.
Inflate.
Make sure there is a low complication.
12. Okay. 14. Okay. Down.
To prepare the side branch ostium very well before standing, just because.
12.
Yeah, here is
14.
okay.
14. Okay. Down.
Okay. After preparation, we also can check IVUS, or we can use NC balloon to push this so that there is low resistance. We can put a stand across the lesion. And
if we check IVUS,
And now check the angio first
Okay, angio.
to show the flow is
ready?
okay.
Okay, angio. Okay, flow is
So-
not good. So maybe
Standing first.
Okay,
Yes.
275, 33.
Yes. Not 33. Oh, 33. Yeah.
And give me a 3.5 NC balloon.那我高压也拆一个。
Could you tell me before PCI procedure, we check the ACT after heparin?
Nearly 400.
Oh, okay. So ACT is good. And before PCI, we give the patient dual antibiotic therapy.
Right.
Which kind of the medication? Aspirin or clopidogrel or
aspirin.
ticagrelor?
Yeah, ticagrelor.
Okay. So we will perform the DK crush for the case. First, standing crossover to the side branch. Another NC balloon to prepare to push into the LAD to prepare the first crush.
小看我一开始的是注意。Okay, good. 足位加大，足位加大。Cranial, more cranial, more cranial. Yeah. 45, 45.
So it's very important to push the NC balloon distally with a size as approx. No, what's the size of the NC balloon?
3.5.
3.5.
Yeah.
3.5. What's the length?
The length is 12 or 15. 12, 15.
Okay, 15.
Okay.
So make sure the stand was full cover the whole region of the side branch, especially for the osteo. It's very important that we cannot avoid
picture. Okay. So how about here? Chief, how about here?
About here?
Seems like okay.
How about the proximal distal? Okay.
Okay.
Inflation.
Inflate. 8.
Okay.
Wait second.
Okay.
10.
Okay, down.
12. Okay, down. Yeah.
So after standing with at least a nominal pressure, we will pull the stand balloon a little back to make sure the side branch ostium optimization. That's very important before first crushing. Here.
12, 14.
Okay.
Yes.
Good.
We can see the stand full expansion, especially at the osteo side branch. So it's very important that we call it the side branch ostium optimization technique.
Oh, flow is not good.
Stop here. We can see what's the reason of the slow flow. Maybe there is distal dissection. How to do next? Okay, Ivers, please. Just because we give the patient dual antibiotic, including aspirin and clopidogrel. Another is heparin. Okay, make sure the Y is there. Okay. OC, Ivers, please.
But Chief, we have a 3.5 balloon preload. Yes. So
3.5 balloon.
Yeah. Maybe Ivers cannot.
This is the same branch guiding casket. Okay, that's no problem.
Okay.
No problem. So if we find this phenomena, we cannot put angio hardening just because maybe there is a dissection at the distal part of the side branch, distal part of the stand. Okay. If there is a dissection there, we use another short stand and a lower size stand there. Push.
Okay. No resistance.
It's very important that we cannot perform crush here just because the side branch are push a little resistant.
Yeah, a little.
Okay.
But it's okay.
Put it back.
Okay,
Distal.
Okay.
Pull the wire
more
distal.
distal.
Pull the wire distal.
Okay. How about here?
No. Okay.
No.
I will pull back.
Okay,
yes.
pull back.
Distal vessel is normal.
Yes. There is no dissection. A small side branch coming.
Yeah.
And the vessel is normal.
Seems okay. No hematoma.
It's very important to use intravascular imaging, especially IVUS. OCT is a lot better here, just because there is low flow of the side branch. It's very interesting. We don't know what's the reason of the slow flow. It's okay.
Seems
No,
good.
Okay,
no
okay.
dissection, no hematoma.
Yeah.
Okay, we think this age of the stand is good enough. There is
Yeah.
no dissection, no hematoma, and we think the slow flow was because diffuse lesion here.
No thrombosis.
Okay, we can
in the stand.
use CCB just like an nicaragradal or call ATP. We have ATP.
ATP.
Yes, ATP, please.
Maybe the baseline attenuation plaque.
Yes, that's a very good indication for we define the reason of the slow flow. We can go back. Okay. After that, after we check the IVUS into the stand back, and we use ATP.
Okay. Do we need to give 2B3A, Chief?
And I think yes, we can use 2B3A. Just because before procedure, we give the patient the aspirin and the ticagrelor. And the loading dose is okay of the ticagrelor.
Stand position good and protruding, small protruding, right? Okay.
Yeah.
So
Good,
yes.
Good. Okay, good. Maybe
Okay.
I will stop.
protruding. Okay.
I will stop.
Stop IVUS.
Okay. After we give the
Give me ATP.
ATP.
Okay.
I think the flow will recovery. It's very interesting.
ATP.
So, Dr. Pan, would you show me the original IVUS result of the side branch? There is a attenuation.
This is the side branch.
Yes.
小白原始的对角质。So Chief, you want to see the plaque
Is it
yes,
attenuation plaque?
Yes.
yeah,
Here.
characteristics. Yeah.
Here.
Maybe unstable.
So this is why after we prepared the lesion with the NC balloon, we can see the flow was not good. After standing, the flow disappear.
Yeah.
That's the reason why. If we cannot recover the side branch flow,
Flow is
okay,
good.
okay.
Better
we
than before.
can use
Yeah.
a mitral catheter to insert in the side branch. This that we give the ATP. Yes, we can check the angel.
Okay.
After the flow recovery, we use balloon
piece.
crush.
Seems good. Better than before.
It's good.
Okay.
It's better.
So,
Okay, we can perform crush.
Crush. Okay.
Okay.
Give me 10 to the spider view.
Yes.
Spider
After slow flow, we will avoid to post dilation at the side branch for several times. We avoid this operation.
Okay, very
just
good.
because
Yeah,
it can make the flow slower and slower.
Inflate.
Okay.
10.
Yes.
Crush the protruding stand. Okay, 10, 12, 12, 14.
14.
Okay, good.
Okay.
Okay, done.
Okay, we can use a lower dose of 2B3A.
Okay, give me 2B3A.
Okay. Is any
2B3A.
attenuation
Okay,
plaque
once
in
more.
the LAD proximal?
12, 14.
LED?
LAD plaque is also calcified lesion.
Yeah.
Okay, without any soft plaque.
No
Okay.
attenuation
Okay.
plaque.
Yes.
So Chief, do we need to check IVUS to confirm the cross stand?
Based on the IVUS, we can see the proximal reference was 4.
Need a forward balloon. Okay, give me a short forward balloon.
Give me the pot balloon, please.
Okay.
We have a pot balloon, very interesting. It's very interesting, and it's very to perform a precise precise crush, just because the yes.
4.06.
Pot balloon. This kind of pot balloon was designed by Dr. Shaoliang Chen, and with a very short length and a very short shoulder. It's and precise, just according to the IVUS finding. It's very useful to perform a pot and perform the precise crush. And the first crush we use 1-to-1 according to the proximal part of LAD, so the pot balloon shoulder cannot cross over to the criner. It's very important to avoid more criner shift.
Okay,
So test.
Please. Yeah.
Make sure where's okay.
Yes, good.
Okay.
Inflate.
Just 10. At the proximal part of the bifurcation
12,
cannot.
12, 14.
Yes, we can see from the angel the balloon has a very short shoulder. Push leader.
Leader. Okay. Okay.
No, no.
Gain. One more gain. 10.
Yes, enough.
Done.
Okay, done. This is a full pot balloon with very short shoulder and short length.
Okay.
Okay. After that, we can
check IVUS.
Yes, we can check the IVUS.
IVUS ready.
If the crush was completely, we can perform the rewire from the proximal part of the side branch ostium.
IVUS.
Okay.
Okay, this is the first crush.
Just give me another run through wire. New wire.
Run through.
Yeah.
Another wire.
Yes.
Okay.
It's very useful to use a third wire to rewire the side branch with a mark of the gelled wire there.
Okay.
So I was just at the prox. Yes.
Go back.
I will pull back.
Yes.
Okay.
Here, this is a LED and diagonal bifurcation. And here we can see double
Scan.
layer.
Fully crush?
Yes.
Yeah,
Okay.
crush is good.
That's
Yes.
good. Okay.
Crush completely.
I will stop.
Fully crush.
Yes. After we got this kind of a result, we can perform rewire. So rewire cannot will be avoided under the first stand strut. It's very, very important. Sometimes we use I have to recheck again after rewiring from to the side branch. Make sure the wire was not under the stand strut. Another is rewire position from the IVUS. So the jet wire was also usually located at the proximal part of the very proximal part of the side branch. So we can use this marker to guide the third wire rewiring.
Very smoothly.
Yes.
Okay. So
if we rewire the correct position, so the wiring side branch was very smoothly load resistant. This is another indication for indicate our rewire position.
Okay.
If we don't have any intravector imaging. So this is LED wire.
LED wire.
Okay.
Yeah, we check the rewire.
Okay.
Cell.
So if rewire position is good from the IVUS detection, so we push the 1-to-1 NC balloon to the side branch very easily.
Okay, IVUS.
Okay, here.
Yeah, more distal.
More distal.
Okay.
Yeah.
How about this?
Okay, I will pull back.
Please.
This is this.
At 6 o'clock, we can see diagonal.
Yes,
this is a crinal.
Yes.
This is maybe guide wire. This is guide wire.
Too many struts.
Too proximal.
Yeah.
Proximal here. Yeah.
Okay.
Okay, it's okay.
Okay.
Okay, thank you.
Be sure it's passing through the proximal here.
Yes.
Give me 3-5 NC balloon first.
So first NC balloon according to the middle LED, another NC balloon to the diagonal. It was according to the I was finding the.
Chief Hopper, I'd like to use the 3 balloon for the diagonal.
So according to the reference diagonal.
3 is okay, or 275.
275 is okay. Just,
yeah,
because according to the IVUS.
Okay, give me 275.
Another.
台上有 we have. Thank you.
So this is 3.5.
This is 3.5
in LED.
Yeah.
So.
Okay, Doctor, please give me English. I will.
So another is 275.
Okay, 6. That's 6. Okay.
Stop here.
Okay.
No, down.
Okay.
We don't need to use 3.5 to pre-dilate again.
Okay. 275. Yeah.
We also use the NC balloon to perform the kissing, not only for the first kissing and second kissing and the final kissing. We also want to use NC balloon and little protrusion to the LED and the shot.
Okay, very smoothly.
Yes, okay. This is a 275 NC balloon.
Okay.
cross the side branch ostium.
Okay, Chief, I just want to push dilate the distal segment. Okay.
No problem.
Okay.
Okay.
Okay. Granule.
Okay.
Granule.
Okay.
275. Okay, AP is okay. AP cranial is okay.
Okay.
I can see the struts.
Okay.
It's okay. Okay, just give me.
Enough.
Okay, 12.
Enough.
12, please.
Okay.
275. Okay.
Huh?
12.
Okay.
No, not this one. Not this one.
Is it here?
Yeah. This one. Okay. 12.
12.
Okay. 14.
14.
I will pull back. I'll pull back a little. Okay, please. 12.
12.
14.
14.
16.
15.
Okay, done. Okay. 16. 20.
20.
Okay. Dr. Gan, please move to the spider view. So Chief, next we will perform the first kissing.
Yes.
Okay. One by one, non-combat balloon.
So the kissing is
Yeah.
balloon size selection according to the distal
16. 18.
part of the two branch.
Okay,
So
good.
one is LED, one is diagonal. From the IVUS, we can see the middle part of the LED was a reference diameter of
Okay,
3.0, but a little approximately
10,
3.5.
12.
Yes.
Okay, done.
Enough.
Okay.
Okay. After sequent pulsation with a little higher pressure, with a moderate pressure, perform kissing, about 12 atmosphere.
Yes.
Okay. After that, we check the flow.
Okay.
Please.
First. Okay, you can test, please. Small test. Okay.
Okay, flow is all good.
Okay.
Flow is very good. So we can standing LED.
LED in the membrane wedge. Okay, move to the cranial view.
Based on the IVUS finding, LED stand selection is 3.0.
30.
33
36.
36.
36.
Okay.
Chief.
36.
36.
36.
Yeah.
Yes.
Picture. Okay, good. Okay, stand. Okay.
So this is 3036 domestic drug-eluting stand.
Second. Okay, just here. Small test, please. Okay.
Okay, I think
give a
yes.
picture. Give you a picture. Okay, how about Chief?
No, need the back.
Only back.
I need the back.
Okay. Oh.
Just because just at the
bridge,
side
right.
of the micro bridge.
Okay.
Test,
please. Seems
yes,
good.
yes, it's good.
Okay, inflate. 6, please.
Okay.
6.
6.
Yeah.
6.
8.
8.
Wait a second. 8. 9.
9.
Okay, enough. Give me a zero balloon. Zero NC balloon. I perform the post dilate first.
So it's very important to perform a very good post dilation before rewind the side branch. One is at the proximal part of the LED, just because there is a big mismatch between the standard diameter and the reference of proximal LED. So the standard diameter was about 3.0, but the proximal part of LED was 4.0. There is a big mismatch. After personalizing with the 3.0 to the here. And
right.
yes, proximal we will use a 4.0 pot balloon to perform a precise post-dilation. We cannot avoid crossover to the
12.
criner.
14. Okay, now. So.
This is 3.0.
Yeah, Dr. Han prepared this 3.5 NC balloon. Okay, here, inflate.
3.5.
Okay, 12, 16. 18.
18.
Okay, enough. Give me 3.5. Okay. And also the 4.0.
Yes, for port balloon.
Right. 3.5. Give me 3.5.
Sometimes if we standing in a main vessel with a very short length or not very long length in the proximal part of the left main vessel, we like to use a jet wire tactic. We cannot find any resistance when we pull back the side branch wire. Sometimes we
So
don't.
I have question here. Do we leave the wire here or otherwise just
leave the wire there, okay, just because proximal length was lot longer. If we met this kind of phenomena, proximal part of ARD was very long with very total lesion or very calcified lesion there. If we perform very high pressure post dilation at the proximal part of ARD, we cannot pull back the side branch wire, I mean the jet wire very smoothly. Sometimes we use angle tactic. So here, after that, yes.
Follow the
full balloon to perform a port.
First port.
Make sure there is low metal position at the proximal part of the area, and after that we rewire to the side branch. We can avoid the wiring under the stand strut. It's very important.
Spider will fix spider view. Wired.
If the proximal part of proximal main vessel standing was very longer, just like longer than 20 or 30, we avoid to jet wire tactic for this kind of situation. So it's 4.0.
Yeah, it's 4.0. Reuse the balloon. It's a reused balloon.
Yes.
So maybe some resistance.
Deflection, please.
Okay, inflate.
Balloon deflection.
Deflation. Yeah, deflation.
Deflection. Okay. For push.
I will insert again.
There is a crossover phenomena of the
some resistance. Maybe I need a new one balloon. New one.
We cannot two-wire crossover at the proximal part of ARD. That's not because of the profile of the balloon. Show me the previous one, Angel. Show me the previous one,
please.
Angel.
Okay.
Show me the previous one, Angel.
Okay, please.
Okay. Go enough. Enough.
Okay, so Chief, the new balloon very smoothly passed through the stand, just because they reused the balloon. Okay.
Yes.
Okay, just here.
Test. It's very important to cannot push the port balloon over the cariner. We cannot over the cariner. Okay, enough. Enough.
Okay. 6, 8. 6, 8.
So another important issue is cannot push, cannot pull back the balloon over the stand. There is no look.
Okay.
Okay, enough.
Okay. Run through wire. Previous run through wire.
Yes.
Yeah, we perform she will perform the second rewiring.
After rewiring, we check the wires from the main vessel. We can see if the wire was under the stand structure, or we cannot make sure the rewire position is good.
Okay, seems
from
good.
From the angel.
Yeah.
Yes.
It's the last angel.
So another important is jet wire is another marker for the rewiring. This wire is also located at the very proximal of the side branch ostium. So sometimes we will rewire near the jet wire.
Okay, I will near rewiring just near the.
Okay, we can use a pullback tactic.
Give me Tucker.
Yes.
Please.
Tucker.
Please.
Pullback tactic. Yes.
Okay.
We can make sure the tip of the wire was Yes, pull back. Yes.
Okay.
No.
It's, yeah, too distal.
Yes.
Here
Okay.
is okay, I think. Here is
Put it. Yes. Here is okay.
Yeah, approximately.
Push.
Okay.
Push.
Yeah. Maybe
Energy resistance.
test.
Yeah.
Test. No resistance.
Okay. Here is okay.
Here's
Push
okay.
little bit. Push.
Okay.
Push. Okay. Check with
Check
the IVUS.
Okay. IVUS, please.
Yeah. So
the LED IVUS.
yes, I think it's very useful to for us to recheck the rewired position after main vessel standing and after personalization of the main vessel stand. So we also can see is rewired position is good, and we check the position of the jet wire.
Okay, Dr. Tan, please.
Okay.
Yeah, I will pull back.
Yes.
This is the secondary wire.
Yeah, secondary wiring.
Okay.
Make sure the wire position.
Okay.
Stands at position, good.
Here, 6 o'clock, we can see the diagonal. We're joining LED. And here, this is guide wire. Hey, we sure it's passing through the proximal CR2.
Yes.
Yeah, I will stop.
So
Okay.
proximal.
The guide wire. Here, we can see this is passing through here.
Okay.
Yes.
So proximal, right?
Proximal.
Okay, thank you. Thank you. Give me the 3.5 balloon and the 275 balloon.
Push the wire a little distally.
Okay. Okay, Chief. Get the wire. Give me 3.5 balloon, NC balloon, please.
Yes.
Please.
So rewire procedure performed with pullback tactic with U-turn tactic.
No, not new one.
And we also use IVUS to check the rewire position. Trials, we also can see the trials rewire position is very good. After that, we can find another very, very useful phenomenon. We push the NC balloon crossover to the side branch to the side branch very easily. This is
3.5
NC balloon.
Yeah, reused
Okay.
NC balloon.
The 3.5.
Okay,
3.5.
275. 275.
275. So 3.5 balloon to LED first.
Yeah.
Two 275.
You want.
275.
You want 275.
Yes.
Okay,
Easily.
thank you.
You cannot find the 275.
275.
So very smooth.
Yes.
Pass through. Okay.
Easily.
Yeah, easy, very easy. Okay, side branch.
The branch?
Side branch first.
Okay.
In plate.
12.
12.
Okay.
14.
14.
16.
16.
18, 20.
18, 20.
Done.
So this is
good.
perform the high pressure balloon to post dilate
Mid branch, please.
Mid branch.
the side branch ostium. That means
14.
14.
makes the side branch
16.
ostium
Okay.
optimization. After sequence high pressure balloon
12.
at
Goes
the
to
LED
12,
and
10. Okay. 12.
side
Okay,
branch.
done.
Yes, moderate kissing balloon perform with short protrusion to the LED. After that, we check the angel and the IVUS again.
Okay. Give me the 40 by 6 port balloon.
Report, final port.
Yeah, final port.
Yes.
4.0那个 port 球囊。
You want.
Okay, Chief, this is the
4.
Yeah, from the
Hangzhou
angel,
one.
we can find the result is very good.
You want.
Port balloon, 4 port balloon. 4 port balloon.
Diagonal flow
No.
is okay, recover. Yeah.
Transit. 4 balloon.
Oh.
Yes, full NC balloon. So the final part is position is very interesting. Compared with original, the first part, the position is not same. So the final part we cannot avoid the crane again. The crane was stand-strut crane, not the original crane. So we just near the POC area is enough. Test, please. Test.
Please.
Test. POC
Okay.
a little more.
Retrieve a little more. Okay. Okay. Here, just okay. Please. 10,
10,
12,
12,
14.
14.
Okay, done.
Enough.
Okay.
So final IVUS check.
Okay.
Nitro, give me nitro.
Nitro?
Yeah,
NTG.
nitro.
NTG.
Okay.
Okay.
Please move to cranial. Move to cranial.
So we check the IVUS
IVUS.
first, just because flow is okay. From the angel, we can find the full
Not
expansion of the two stand, even at the bifurcation site. Both of the austere LED and not austere side range and the proximal LED. After that, we check the IVUS from the ultimate trial result. If the final IVUS result is good, so the patient outcome in the future is good.
Please. Okay.
Yes,
good.
yeah,
Good.
it's okay.
Follow me.
So this is IVUS.
Yeah, IVUS.
Final
Final
check.
IVUS. Yeah. Just
Yeah,
follow
I
me,
will
follow
pull
me,
back.
follow me.
This is a distal
Okay,
LED.
just here.
The IVUS is in muscle bridge.
Yes. We'll find the landing zone is good or not.
Good.
We cannot find the landing zone of the LED stand.
100 seems good.
Down my kind of bridge here. Yeah.
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 Okay.
This is a distal stand edge. It's low
Yes.
dissection.
Seems
Okay,
good.
so-
Okay. Good.
The stand diameter about 30.
30.
Yeah.
The distal reference was 30.
So yeah.
So I think maybe the distal, I mean, near the landing zone stand a little on the expansion.
We use the zero pulse dilation flow.
Yes, the distal landing zone.
Use the 16 atmosphere.
So we can calculate the satisfaction of the stand display.
Here, this is the LED on the diagonal bifurcation.
Yes.
Okay.
The stand
Good.
crino.
Crino was very short.
Yeah.
Very short.
So proximal part was very, yes.
The
Standing-
proximal
yeah.
stand.
Yes, I think standing landing zone proximal was very good.
Very good.
Okay, I will stop.
Okay.
Yes.
Okay.
So the final
Yes. Okay.
diagonal IVUS. Okay.
Proximal stand edge
Do it.
low dissection.
Yeah.
Mhm. So before
I will check the plug burden.
Yui, could you please give me another angel?
Another
Just
angel?
the- yes,
Please,
just
angel.
angel.
Angel, please. Angel, please.
I think
Take a
the
picture.
deadline time is now.
Okay, chief.
The plug burden is not more
Okay,
than 50.
okay.
Okay, seems good. Yeah.
Yes.
Right.
And
The
here the
fi-
distal,
Yes.
this point may be the minimal stand area.
Yeah.
Okay. Okay, Dr. Pan, this is the final IVUS for
Okay,
first
okay.
diagonal.
The LED minimal stand area is more than 6 millimeters
6.
square. Yeah.
Okay,
So this
diagonal?
is a diagonal.
This is the
yes.
diagonal. Yeah, I will pull
Okay.
back.
Please
Okay.
go back.
The distal vessel is normal.
Yep.
One side branch. Joinment vessel.
Yes. Thank you.
Thank you. Thank you.
Thank you.